Hello, everybody. Nelson Virgil here with excelmail.com. I'm very happy to have, I consider you a friend, Dr. Walker. Dr. Walker is really one of the fathers of growth hormone, releasing hormone, and peptide research in this country. He's got a very interesting background. He's got a PhD and an RPH, and is well known to have developed Cerrone, a growth hormone releasing hormone. He received a bachelor's in pharmacy from Rutgers University and a master's in biochemistry from New York State University, and a PhD in physiology from Rutgers also. He completed an internship in neuroanatomy and electrophysiology. Those are handfuls of words there, from also from at Emory University College of Medicine, and a postdoctoral fellowships in neuroendocrinology and neuropharmacology at Duke University College of Medicine and the University of California in Berkeley, respectively. Dr. Walker held tenured faculty positions at Clemson University and the University of Kentucky College of Medicine. He left academia for a brief hiatus in the pharmaceutical industry, serving as a director of toxicology at SmithKline Beachem Pharmaceutical Corporation. At the same time, he was also research professor in the Department of Pharmacology at the University Medical College of Pennsylvania, and later at the University of South Florida. In addition to his research duties at USF, Dr. Walker also served as director for research compliance and also the director of USF Cares. He has been the recipient of many federal, state, and local research grants, and has published extensively about senescence, aging, and treating functional deficits associated with aging. Dr. Walker is currently editor-in-chief of Clinical Interventions in Aging and author of the book, Why We Age, Insight into Cause of Growing Old, available on Amazon.com as a Kindle version. So thank you so much, Dr. Walker, for agreeing to, chat with me today, because we have a lot of interest in not only on excelmail.com, but in the different men's health groups that I moderate on the use of growth hormone releasing hormones and peptides when it comes to, doing an intervention for aging related issues. So I want to start by, first of all, welcoming you, and also feel free to start telling us, how did this whole thing started? I mean, many years ago, the research in this area.
Well, I really appreciate that kind introduction, Nelson. Thank you. I'm going to make one correction to your introduction, however.
Okay.
I didn't develop Semoran. I made it popular, certainly in the medical community, as a result of my interest in peptides and their ability to recrudesce or rejuvenate, if you will, the pituitary gland. I wish I could say I had a big part in development, but that was other people's work. Certainly I can pay credit to Bill Wernberg, who did a lot in terms of its actual creation. But let me talk to you a bit about, let me tell you something about the history of these peptides, because I have a personal connection to the whole history. I went to Berkeley, as you mentioned, in 1977, and that was, or 1977, 78, and that was a year after Roger Guillemin and Andrew Schally won the Nobel Prize for their work on the neuropeptides and their abilities to stimulate the pituitary. I worked with Paola Timoris. Dr. Timoris was my mentor during that period, and the reason I mention her is that she was working alongside Guillemin when they were at McGill. She was a postdoc. Guillemin was a postdoc. He had gotten his MD in 53, and this was a little later on in 50s. She was there with him, and interestingly enough, although I don't think they were at the same time, Schally also did work at Guillemin. They all went there because Hans Selye, who was a big name, who was still a big name in fight or flight and adrenal responses to fear and to anxiety was there and was a big name in the field. Now, I recall a time when she told me that they were working on in vitro studies of pituitary function, and were particularly taken by the fact that the pituitary would secrete hormones spontaneously in culture, but really did a number if you added a piece of the hypothalamus to the culture media. So this implied an indirect link between the brain and the pituitary, which at that time was unknown. There was no real understanding of how the pituitary worked. The adrenal hypothesis anyway, the anterior pituitary. So Guillemin, she relayed the story to me that Guillemin was excited. He was like at the end of his chair. He said, there's something here that's very important and we can study it and maybe gain notoriety from it. So, so that's what they did. And at the same time, Shally did the same thing. They actually started out from the same blocks and became very fierce competitors that didn't really like each other because the literature is full of disparaging comments. And I've been with both of them. And they're not exactly kissing cousins. But anyway, let me get to the story about this. After realizing that, both of them realizing that there was some connection between the brain and the pituitary, they start searching for a source, searching to identify that molecule. And after killing lots of pigs and sheep and other things, they actually were able in I believe it was 1966, to identify the structure of thyroid releasing hormone, tripeptide, and then also they identified GnRH, a gonadotrophic releasing hormone. So subsequently, they went on to study the rest of them, and they were moving along, but there was a great frustration in their ability to identify growth hormone releasing hormone. Now, unlike some of the other neuropeptides, GHRH and growth hormone axis is species specific. So you needed to get human material. And it was like almost impossible to do that, okay? Because you couldn't grind up enough, you couldn't find enough cadavers to get enough material to actually be able to identify in that mush of tissue what was the active ingredient. And once you did, you then you didn't have enough material to sequence it and be able to identify its structure.
So you couldn't get this from monkeys? This kind of basic research?
Monkeys, we could do it on a basic research, but the idea is that the value only came from human because of its specificity. See, the growth hormones are different for different species. So they don't have the same structures. So relevant to these doctors, basically, and the science, which is, as you know, human-oriented, even though you have a lot of great work coming out of animal studies, the primary stuff is how do we work? So an interesting thing was observed in the books. In history, we have to go now retrospect. We're standing in the hall at, I would say, 1971 or so, searching desperately to find this material. And I don't remember who became aware of it, but it was in the literature for many years that in 1959, Altman and Schultz, there was a couple of authors published a paper saying that they had a patient who was acromegalic. In other words, it's excessively secreted growth hormone. But when they did the typical surgeries to shut down the pituitary, the patient didn't get any relief from the acromegaly. He kept growing. It was a cancer patient. And from that, they inferred that the tumor itself was producing a stimulant that was either growth hormone or the releaser of growth hormone. And in fact, when they removed the pituitary, not in that patient, but when he did animal experiments, that didn't work. So it means you needed the pituitary. It sort of implied that GHRH, or the stimulant at that point, was in the tumor. And so ectopic production of GHRH became aware of other studies of cancer and acromegaly, which is really sort of the way science works. You build on other observations. And so laboring on this concept, then I believe it was Mike Thorner or some other people, I can't remember the exact people, but they found that in pancreatic tumors, there are certain pancreatic tumors were rich in GHRH, in a growth hormone stimulating substance. So since there were, they could locate people with with pancreatic tumors, and many of those produced sufficient excess GHRH, they were then able to extract this media and find it to be a 44 amino acid peptide that was indeed identified as human GHRH. Both of them, fighting each other like crazy, struggled to be first, but they were published on the same time at 1976, I believe it was, 75, 76. And then they were both awarded, because now they had completed the spectrum of neurohormones that regulated the pituitary and their structures. And so they were awarded the Nobel Prize in medicine for that discovery. Now, there are two, here's where the story, there's a dichotomy in the story. I told you how they found it using pancreatic tumors. But prior to that, before that approach was taken, Shally did a clever thing. He had a fellow, or maybe he was just a colleague, more than a fellow, a chemist by the name of Cyril Bowers, who was with him in Tulane. Now, I didn't mention, both of these guys, Shally and Guillermin, came from McGill, and they went to Baylor. And then they left Baylor. Shally went to Tulane, and Guillermin went to the Salk in La Jolla. So they were, it's funny, they started in McGill, they converged in Baylor, then they split their separate ways, but they continued to do the same work. Anyway, while Shally was in Tulane, and he had Cy Bowers, this is the guy I'm telling you about, his colleague working with him, he said, well, we can't get enough material to do this, so let's work backwards. Let's try to go and see if we can synthesize GHRH by blindly making molecules we know exist in the brain modified. We modify them. You're a chemist. Cy Bowers was a chemist, and he had colleagues who were clever chemists. And they started with a very elementary molecule, the medenkephalin, a 4 amino acid peptide that exists normally in the brain. And then they start modifying this peptide. And they would test it for activity in vitro. And they would test and test, and they went through any series of compounds, and nothing really worked to their satisfaction to parallel the activity of GHRH. So one of them that they made showed a little bit of activity in vitro. And that molecule turns out to be one that I worked on when I was in industry. It was his-D-trip-allotrip-D-phenylysamides, a sequence of 6 amino acids. 6 amino acids that carry within its structure 2 dextrorotatory isomers, D isomers, that are not naturally occurring. I'll explain more about the value of that later, but the point being, they sent that, and again, I had a fortunate circumstance. I was at Duke at the time in 75 when those molecules came to us for testing. And they did. You put them in culture, they would release growth hormone, but it would occur over a period of time that was unsatisfactory. It would sort of like seep out of the cell. And so there was a lot of consternation, a lot of arguing that this really wasn't a growth hormone secreting molecule. A lot of people were saying, well, you did a lousy job in dissecting the brain. You got some hypothalamus in there, and that's the reason why it's actually doing that. But after time and time again, it kept doing the same thing, and it was about to be abandoned until, and I don't remember who did this, somebody shot it into an animal, and it blew out the GHRH. It was, not the GHRH, it blew out the growth hormone. It was more potent than GHRH in vivo, but in vitro, it was nothing. So this caused people to scratch their heads, assuming that this was certainly a molecule that could secrete GHRH, but it wasn't GHRH. So it had to be some sort of synergistic system that amplified the activity of the native peptide that was the controller. Actually, it was even wondered if that might have been the original controller, but later shown that indeed the 1 to 44 amino acid was the right one. This was something else. And the reason I say it was something else is because from 1976 until 1999, no one knew what it was. There was no endogenous ligand for that until, again, I was very fortunate to hold a growth hormone meeting in Keystone. It was actually a ski meeting. We did a lot of skiing over there. But we also taught science. And this guy, Kojima, came from Japan and made a startling presentation that he had discovered a substance in the stomach that bound the receptors and did the same exact thing as the artificial amino acids that were synthesized by Bowers. And so this was tested over time and indeed was found to be another molecule produced in the stomach, subsequently found also to be produced in the brain, that was named Geralyn. They just made up the name, the Japanese made up the name, and of course, whoever names it first, that's the name that sticks. So the problem then with the investigators was, well, if this doesn't stimulate the pituitary, how does it work? And in the interim between then and when they found out, there were speculations on, well, maybe it's suppressing somatostatin, because we knew about somatostatin. But when you suppress somatostatin, as with arginine, large doses of arginine IV, you don't get a spike of growth hormone, you get a rise in growth hormone. You don't get that stimulatory effect. So it wasn't sure if it was that or something else. And then the realization came out that this substance was actually stimulating GHRH. And not only was it stimulating its production and its release into the pituitary portal system, so it accessed the pituitary gland, but it was also suppressing somatostatin. It was a double whammy. It was stimulating that, and then it was stimulating GHRH, and it was inhibiting somatostatin. So a very, very interesting finding that you have a modulatory substance that works in the brain to sort of regulate or amplify the natural growth hormone release. And in fact, it can override any inhibition on the natural activity by overriding somatostatin and stimulating GHRH. So then the question was, well, does this stuff work in the pituitary too? Because we knew when you put it in pituitary culture, it actually causes something a little bit to come up. And indeed, in about, let's see, at this time, we're in the 80s now, and I'm just leaving Kentucky and going to Pennsylvania, and I'm just about to enter industry, and Roy Bowers, and not Roy Bowers, Roy Smith was at Merck. He and others were working on the binding of molecules in the pituitary, and we're looking at the receptor sites for these things. It wasn't only Roy Smith, there was a lot of other people involved too, but he was familiar to me. We're friends in a sense. So we discussed that. I gave a seminar over at Merck regarding the stuff that we did, and he talks about his binding studies quite a bit. But what's interesting was that two different receptors were located on the pituitary, one for GHRH and one for the GHRPs, as they called them, the growth hormone releasing peptides. Now, this nomenclature is interesting because subsequently, the group at Merck screened a lot of molecules that I had synthesized, and came up with two or a couple of them that were not peptides, but served to saturate the receptors for GHRP, just like GHRP, and synergized with GHRH, just like GHRP. So the nomenclature for the GHRPs then and this other category became GHS, growth hormone secretagogues, of which there now are these two categories. The peptides, the non-peptides, those are in the GHS category, and the GHRH molecules that are the native molecule, let's call it that. Now, what they found was that within the pituitary gland, the GHRH molecule activated that GHRH receptor, and it could not be downregulated by the GHRPs, only downregulated by itself. So you get tachyphylaxis only on your own receptor. Same thing was true by GHRH, but the GHRP inside the cell would activate a different second messenger that amplified the signal from the GHRH site. There are second messengers, as you're probably aware. Protein kinase A is one of them that's activated in the cell in the pituitary by GHRH. That protein kinase A increases cyclic AMP inside the cell, which then facilitates not only synthesis of growth hormone in the cell, but also blows it out. On the other side of the equation, the GHRPs or the GHSs stimulate GH1, the gene that actually causes production of growth hormone, but they have no effect on release. They only spill it when it gets so filled that equilibrium favors release. That second messenger is a protein kinase B, and it works through a calcium flux, and that calcium flux in some way potentiates the activity of protein kinase A and cyclic AMP. So you get this huge release that you wouldn't get for either one. So the potentiation then works at both the pituitary level through the process I just explained, and also in the hypothalamus, because GHRH, don't forget, doesn't work in the, let me get back to that. GHRP goes up and stimulates GHRH, but GHRH exists in the hypothalamus. Now, this brings us then to our pharmacology. Did you want to ask any questions on this history? Or
yeah. Let's stop here and clarify some terms, because this is definitely very technical for a lot of my guys. Explain again the difference between growth hormone releasing hormone, GHRH, growth hormone releasing peptides. Okay.
Yes.
And obviously, we have the growth hormone releasing secretagogues. So, and that includes both, right?
Yes.
So we have the pituitary producing growth hormone releasing hormone, obviously, to stimulate the hypothalamus, right, to stimulate the pituitary gland to produce growth hormone. So GHRH stimulates from the hypothalamus to pituitary gland. So we have these other molecules that were discovered, obviously, in the lab. There are peptides, and Geralyn, which is the molecule produced, or their hormone produced by the stomach lining, is that a peptide Is that what is that?
Yes, that's a peptide also. It's a 28 amino acid peptide. It's a big, it's about the same size as Semoran, okay,
Mm,
which is 29 amino acids.
mm,
But it has other functions. It has multiple functions, as a matter of fact. It's not only a growth hormone releasing agent, and by the way, it's also produced in the brain.
mm.
The majority of it's produced in the gut, but it's also found in the brain, co-localized with another neurotransmitter, dopamine. So those two things together stimulate the GHRH neurons. Okay.
And once again, ghrelin produced in the stomach lining increases when we're hungry, right? When we're fasting, and there may be a physiological reason for that,
Oh
right?
yeah.
What is it?
It controls energy metabolism. It's actually balanced with leptins and other things to regulate the food intake and to balance energy distribution. So and it does other things too. It actually affects the immune system. It tends to reduce the accumulation of pro-inflammatory cytokines like tumor necrosis factor and interleukins. It's beneficial in that sense, and it's also been shown to be reparative, if that's a proper word. It repairs damage to the heart that's induced experimentally with drugs or alcohols or other things. It has a broad spectrum of effects. We only focus on growth hormone because of our interest in the synergy, which has a good application clinically for people who are growth hormone insufficient, people who want to increase their growth hormone output. So what's really sort of nice about the dichotomy too is that the GHRPs have a growth hormone effect at lower doses than they do the systemic effects that are elicited in the gut. So you can titrate for the growth hormone effects without having this hunger dominance and other effects that may not be acceptable to the patient by the physician carefully regulating the dose with his patients or his or her patients. So that's that. I could tell you more now about something else if you want to leave that subject, or we can still talk.
Yeah, I'd like to actually get into the actual development of Cerrone. When was that? When was the actual? When was it Merck or was it Sirona who actually produced?
No, it was neither.
Mm-hmm.
It was developed. Now, Bill Wernberg, who was, I guess, a postdoc and maybe then became a colleague at La Jolla with Guillermin, one of the Nobel laureates, was charged with the task of figuring out how much of this molecule or what part of the molecule is effective for releasing growth hormone. Is it all necessary or is some of it necessary? And he chopped up that molecule and tested the fragments. And indeed, the 1 to 40, which is a big fragment, is effective. But the smallest fragment that's still effective is 1 through 29 amide. Okay, so the amidated form of the 1 through 29 fragment did that. Bill Wernberg published on that, I think in 1979, 1980, somewhere around that. Now, the knowledge of having that kind of reasonably small peptide that it could be used commercially caught the attention of Sirona. And so Sirona bought the rights from La Jolla, from Salk. I believe that's under the umbrella University of California. But anyway, they bought the rights and then they developed it. They took it to an NDA and
New drug application.
New drug application, I'm sorry. And marketed it as Geralyn, G-E-R-E, no, G, I don't know how to spell it. Anyway, not Geralyn, Geref, G-E-R-E-F. Now you can hear the word GRF, growth hormone releasing factor. So it's derived from that name. And so GRF then was marketed by Sirona in the late 80s, I believe. Now, it was first used diagnostically for kids that couldn't grow to see if their pituitary worked. And then it was also marketed at higher doses to be used in growth hormone deficient kids to help them grow. And it did. The only problem was that Sirona was producing two growth hormone substances, Sison, which was a recombinant growth hormone, and GRF, which was a stimulator. Now, without being a scientist or without knowing anything too much about this, one could sort of intuitively know that the recombinant growth hormone, the finished product, is going to give you a faster result than one that has to recrudesce your body and recrudesce your pituitary and start you producing your own growth hormone. So in a way, not in a way, in fact, Sirona was competing against itself. Its products were competing one against the other, and GRF was losing because GRF, while effective, and in fact was more effective than recombinant growth hormone, than Sison in growing longer period of time, people wanted results fast. So there was more Sison being sold than GRF. GRF was losing money, and they got rid of it. I happened to have the good fortune of knowing that prior to its happening. So I was in conversation with one of the people at Cerrone Asif and said, why don't you use this for aging, anti-aging, where you have muscle loss? Because this now was after, it was around 1990 when the paper had come out to show that growth hormone was good for restoring muscle mass in aging people. And his answer was an obvious one that I knew, but I wanted to hear him say it anyway. The FDA would not approve it for that because aging is not a disease. So they had a product that they had a potential use for, but they could not get an NDA for it. And they didn't even try because they saw it to be a relatively small market. Not so. But nonetheless, they saw it that way. So when that came off patent and when it was available for general use, I guess I would say, I was very enthused about that. I wrote some papers about it and actually went and started talking about it. And this is where you're talking about my input on the developmental side. As I said, I didn't develop the product, but during that time from the 1990s up to now, I promote that product as a valuable resource for people who basically stop secreting or slow their secretion of GHRH with advancing age. Now I have two opinions, one about the Semoran and one about the GHSs, but we could talk about that later if you have any question about this first.
Yeah, no, let's stay on Cerrone first, because otherwise we're going to complicate the
Sure.
subject matter.
Yeah.
So Cerrone abandoned it. It basically was it's an abandoned drug, so it's FDA approved for an use, or two uses actually, for growth hormone deficiency too, or only for children with growth issues?
Well, it was only approved really for children in growth.
Okay.
That's where it has formal approval. It may have subsequently got approval, but I don't know who would brought that forth for adults. But recombinant growth hormone does have an approval for adult growth hormone deficiency. So I think by implication, the Semoran molecule would also be effective, although slower than you would expect. The good part about it is it's physiologically more relevant than recombinant growth hormone because it restores the competence of the pituitary gland, which is lost when you give recombinant growth hormone. basically by negative feedback cuts off the brain and pituitary, causes disuse atrophy, and those tissues then become dysfunctional or they lose function. You do get the desired peripheral effects, but you stop the physiology. And me being a physiologist, I'm always interested in sustaining as much as the body's total functions as we can. So,
so the legalities of Cerrone in 2017, can you talk a little bit about that, the actual use?
I know it's widely used. It's widely prescribed as an injection. In the late 90s, I did the first experiments for subcutaneous administration. It was only thought originally to be effective because of its molecular structure, and it was thought to be vulnerable to cleavage by endopeptidases and other enzymes if you injected it. But I didn't believe it. So I felt it was small enough that maybe some would get in. So a group of 6 of us, I was the oldest at that time, I think was in my 60s, 65 or something like that. And the younger guys in their 50s, all doctors here in Tampa, we injected ourselves for a month with doses as low as 200 micrograms. One dose, not per kilogram weight, but we were all different weights, but we just guessed at a number because we had no idea really. I had taken up to 1 milligram IV and I didn't feel anything, but I felt that maybe that was an overkill anyway. I had done that both with GHRH and also with GHRP, and try to derive some sort of reasoning for using subcutaneous dose of 200 micrograms. It was intuitive though, but for all of us, every single one, our IGF-1 went up after a month. I'm not saying dramatic change, but they all went up over baseline. Subsequently, I reported this both in talks, mostly in talks because I didn't really think it had any value as a scientific paper, although I should have, because it turns out that people did start using it at 200, then went up to 400. I made some comments, I believe, in one of my papers about the gender difference, like females needing perhaps more than males, and I was recommending up to 400 and 500 micrograms. But now everyone uses about a milligram on a daily basis. And there's nothing wrong with that either, because the only thing we know about GHRH are trivial side effects like irritation at injection sites. Although they produce, in 20% of the people, they produce antibodies to the GHRH. Those antibodies are not precipitating, or they do not negate the effects of the GHRH. And they go away for some reason after several months. That's about the only side effect. So using 1 milligram or a couple milligrams doesn't seem to have any kind of safety risk. And there's been none that I've ever found that warn against its use, because it does not create any kind of anaphylactic reaction or any kind of serious immune function. So
a glucose spike, either like growth hormone, can cause.
Right. Oh, no, it wouldn't do that because of the way the response is, especially by subcutaneous. You don't get that immediate boost and that immediate bang. It comes in after about a half an hour and then actually amplifies the inherent release of growth hormone itself.
So where are the actual endpoints? Where are people looking for, clinicians that are using this? Is it lean body mass increases, fat loss, or I hear better sleep? What is it? Or is it just increasing IGF-1 with aging?
Well, IGF-1 has been used as the main criteria because it's a number. People like numbers. They like to say, I went from here to here.
Yeah.
The problem with that is that the numbers go down after a while with Semoran.
Why is that? Why is that?
It's because when you give Semoran initially, you're giving it in conjunction with the GHRH that's already in your body. So it's an additive effect. However, the body sees sermorelin as if it were GHRH. So when that happens, it kicks out somatostatin, and it also initiates what's called a very short loop feedback within the GHRH neurons to not make any more GHRH. We got enough. So your injection then slowly loses the endogenous GHRH and the IGF-1s go down. That has caused a lot of frustration in doctors with their patients. And they're saying, well, should we give it, every other day and stuff like that? And what I would advise is I'll take a vacation or else use another secretagogue that will restore the GHRH if you want to flip like that. So the GHS, as I told you, the peptides and the non-peptidal entities actually stimulate the production of GHRH. So, you could do either. If you're a doctor, you could say, well, I like sermorelin. I don't want to use anything else. I'll just take a holiday for a month. Patients don't always like that, but if they want to get back to levels, that's what they should do. Now, I might make an interesting point, I think. The levels of IGF-1 are not always correlated with the clinical outcomes. So you might have a reduction in IGF-1, but you might still enjoy the increased lean body mass, reduction in fat, enhanced energy, sleep-related growth hormone release, those types of things that are beneficial, but the patient can't see. It's a subjective phenomenon. The objectiveness of numbers is what attracts the doctors originally to using IGF-1. I would say personally, clinical markers are better because if you are losing fat and if you're gaining lean body mass, if you're gaining muscle, then you're on the right track. And put those numbers secondary to those observations. So that's my opinion. Sleep is an ambiguous thing because I've known sleep scientists who work a lot, and it's not a consensus that GHRH will cause you to sleep. What it does is enhance the growth hormone related, sleep related release of growth hormone. It amplifies those patterns, but it won't knock you out. Now, interestingly enough, and I read this, I always held it in the back of my head. GHB, the date rape drug?
Yeah.
GHB is a very potent inducer of sleep, as you would know.
Yeah.
But that sleep is good sleep because that sleep is associated with high amplitude growth hormone as you would have in youth. So I'm not recommending use of GHB, and it's not legal anyway. But
well, it's legal for one. There is one indication for sleep for people that have narcolepsy and they have failed. They have failed other treatments, but it's not an easy prescription to get. So.
Yeah. But it actually does enhance sleep-related GHB and does put you to sleep. So that's my comments with regard to GHRH. Yes, it's beneficial to amplification of the sleep-related normal sleep, but it will not put you to sleep.
So the use of sermorelin by itself or monotherapy and the use of IGF-1 as a marker, obviously, and that's what many doctors are doing and patients. I mean, most of the guys on Excel Mail, they plot their blood tests, and they follow them. Most of them are very analytical. And you're telling us that maybe we should be looking more at the clinical outcomes like body composition. So should we be getting a DEXA scan, a baseline, and then maybe a few months later? Is that a way to, because, everything is subjective. I'm getting lean body mass and losing fat, but really, I mean, objectively and measuring the actual increase and decrease, and there's nothing more reliable than, I guess, a DEXA scan, right?
I've had them
full body, DEXA.
I've had them done on myself, and they're very good, and they'll show they'll show the subtle differences in bone as well as in muscle. Primarily they're used for bone, but you could see all tissues, of course. So yeah, the only thing about DEXA, you can't use it too. Yeah, I mean, you can, but you don't want to use it too much because the
No.
radiation.
Variation, yeah. So let's move on to so we just talked about Cerrone as monotherapy. Let's talk a little bit about the peptides that are out there. Some that may be used clinically. Obviously, I don't want to talk about the ones that are available online as research drugs, or we can probably touch on that if you want, because it gets a little gray to me. But why are they, is there a synergy between Cerrone and the peptides, or are the peptides effective on their own in increasing endogenous growth hormone production?
Well, we know that the administration of both peptides, all right, not peptides, both substances, will always result in an amplification of the output of growth hormone. And in my knowledge of the literature and my experience, that will never wane because you are providing the GHRH. Now, what you're doing though is you're putting in the GHRH, not using the body source of it.
That's Cerrone itself.
Yeah, Semoran, right.
Mm-hmm.
So long as you give them together and you don't care about what's going on upstairs, then you'll get a synergy. You'll get a better boost of growth hormone than you will for, well, I guess for either one alone. However, if you were to give the peptides or the non-peptidal forms of GHS, you will always get a bigger response, especially in adults, than you will for Semoran alone. The reason being, as I said, synergy with the endogenous or the stuff that your brain makes, and not only that, but increased synthesis of that. So when you're looking for a spike or you're looking for an output of growth hormone, the Geralyn molecules will give you a bigger one if you give them alone. If you give them in combination, you're always going to get a bigger response than either because you're getting the external effect, okay, of the Semoran, which you're giving by injection, is greater than what your body is producing. So that's my favor, if you ask me personally, because of my background, is that I would favor one, and I would favor the GHS molecules because they sustain more of the growth hormone axis than does Semoran. More importantly, they balance down the somatostatin, which it tends to increase with age, by the way. Somatostatin dominance in aging is very significant. So if you could control that somatostatin dominance, keep it down, keep the GHRH levels up, which again go down with age, then you're playing a physiological role that makes sense. Now, for people that want to bulk up, or for people that want to affect cachexia, people that are really wasting badly, or people want to get bigger, then you give both of them, I think, because they serve the synergistic purpose from the external side. But eventually, I would say I would favor the weaning off of the combination and the utilization of a single factor.
And we're talking about GHRP2. Let's mention a few.
Well, GHRP2, I've used all of them, really, tested them all. GHRP2, I favor because of its potency. Now, these molecules have an interesting chemistry. They all have the last four amino acids. So let me think. Allotripdephylisamides. There's always a D amino acid. There's always an alanine, tryptophan, diphenylalanine, lysine, amide. That piece of the molecule is always the same in peptides. The modifications of the first two affect its potency. In the case of GHRP6, there's a substitution of D-tryptophan for a molecule called naphthylalanine, D-naphthylalanine. And for some reason, the spatial chemistry makes that molecule bind tighter to the receptor and makes it more potent. So I favor, for the work that I do and for recommendations to people who are trying to make a choice, use GHRP2. Now, I've heard, and I don't have a very broad knowledge of this, that apamorelin, which is a 5 amino acid version of the GHS, is used in weight loss clinics. Now, I can only tell you that anecdotally because I've never tried it experimentally. But I heard that that is being currently used and used quite successfully in the countries that have been trying it.
As monotherapy? No.
I'm sure it's in combination with diet.
Sermorelin? No, I mean with another, like with sermorelin combination
No, I think as a monotherapy, but I can't swear to that. So I don't know for sure, because don't forget, apamorelin is although it has a low potency, is touted as being a pure growth hormone releaser. So it does synergize with the endogenous GHRH. I suppose if you gave it with sermorelin, it would be okay. There'd be nothing wrong with that. But apparently, it has something to do not with the growth hormone releasing effect of the apamorelin, but of the neurological effects or the dietary drive effects, something about the effects on food acquisition that is satisfied, the satiating effect of it. Now, that's the opposite of what you would expect for a Geralyn derivative, but nonetheless, that's what's being reported. I haven't seen any papers to that effect, but that's what I hear scuttlebutt from people who are using it.
No data comparing different peptides and, apamorelin versus GHRP2, right? I've been looking, and it's almost impossible finding papers that compare, the same population, because everything changes depending on the population you're looking at. But
yeah, you won't find those one against the other that much. I do have many papers that can be used in comparison that we can talk about at another time if you like, where you compare the benefits, the attributes of each, and say, just put them in a table, this does this, this does that.
Yeah.
And so, but when I think of the actual comparisons, I don't remember reading any peer-reviewed papers that actually discuss it that way.
Yeah, so it's all anecdotal, what you see online, and some conclusions that you can make from papers that look at each one separately. So let's talk about the Geralyn analogs, or like Pierre Morin, or it's called, people call it MRK-677. It's an old Merck drug.
Right.
Let's talk a little bit about that before we close we finish the lecture, the seminar.
Right. Well, when this is now, we're talking 1989 or 1988. When I reported, by the way, I guess I will take credit for it. I was the first to report that the GHRPs were orally bioavailable. We reported that in 1990, although we did the work back in 88 or something like that, 89. Well, that caught interest, obviously, in Merck because that's an oral product. SmithKline, who I was working for, was going to use the product for feed, for cattle production and milk. Never got off the ground for some reason. And because of its bioavailability, they felt they would have to use too much, and in humans, they didn't want to use that. I don't agree with that because it's bioavailable enough to give the effect that I would seek anyway. But as a result of that publication and scuttlebutt about oral bioavailability, Roy Smith and his colleagues start going through just screening all these molecules that they had, that, drug companies synthesize stuff they don't even know what it's for. They just produce molecules. And then, it's like find an effect later.
Reporting in a library.
Yeah. So I was invited to come over there, and they reported that yes, these molecules are much better than the peptides because they're 85% bioavailable. So I said, well, that's interesting. But then it went away. Oh, by the way, I forgot to mention, SmithKline dropped GHRP for several reasons. One of them is in corporations, it's always the boss makes the decision. And if he doesn't like something, if it's not his favorite thing, very often they don't put it in the pipeline. But that was one of the reasons. But GHRP was also dropped because it was a $50 million anticipated product, which is peanuts for a drug company, right?
For what indication?
I guess at that point we were going to do growth. That's because that was the easiest thing, you know. I don't remember exactly, but that would have been the intuitive thing to do.
And we're talking about GHRP 2 or 6.
No, that was 6.
Okay, I'm sorry. I get confused, you know, with these numbers.
Six was the first one. Now, that doesn't sound right, I know, because there is a 1, 2, and 3, but none of those.
Yeah, we don't talk.
Good. 6 was the first. 2 came much later, but was shown to have greater potency. And then these molecules that were produced by Merck were shown to have greater bioavailability. But now, anecdotally, and I've been studying them lately because I have interest in their GH releasing potency, they seem to have a greater effect on appetite than does GHRPs. I tested it too. As a matter of fact, we were trying oral, and it is the most horrible tasting stuff. It will knock your socks off.
Well, you know, because you actually tasted the inside of the capsule. But,
oh yeah. Oh no. I was not knocking it for oral bioavailability. It's great for that. It's terrific. But if you taste the molecule and want to make an oral preparation that's liquid, then you have to mask it. And it's very difficult to mask. Well, that's true for GHRPs too. They're all not good tasting. So,
but there's nothing wrong with taking a pill. I mean, once a day.
No. I wasn't suggesting that at all. And I don't even know if this differential in appetite is real or not. This is just words that I'm hearing. I don't see in the literature anywhere a comparison between orexigenic effects of those molecules with the peptides. These are things that we have, unfortunately, in our sphere that people say and then believe. So
I'm one of them, you know, I've tried them too, and I can't stop eating on Morin. And it's the reason I have to stop the drug because I gain weight too much too fast. But, you know, if I was wasting with HIV, it would have been a great drug, you know, back in the day, because it's oral. You don't have to inject it. And it has other benefits too. Actually, make my gut, I have IBS, and I felt my IBS is gone. I mean, the inflammatory response, I think there's something there. It decreases inflammation. So my question to you is, because I've read all the papers on Morin or MRK 677, and there's a lot of really good data that Merck produced for sarcopenia, for older people, males and females.
Terrific.
I mean, the safety looked really good. I mean, only one signal when it comes to, I think, arrhythmia or something. But I never understood why an oral growth hormone enhancer with good safety would be abandoned by Merck. And I know you said that it's very hard to get anything approved for aging because aging is not a disease under what the FDA considers a disease, or for sarcopenia, which is the loss of lean body mass that we experience through aging. But even for a wasting illness, I mean, we have many different wasting syndrome related illnesses. So I've always been curious, and I wish I could talk to somebody from the higher up in Merck to see why a drug like this was abandoned. And obviously it's available. Many people are getting it either through compounding or through online companies as research molecules. But can you expand on that?
Yeah, I can give you a couple of reasons. One of them is that you already said aging is not a disease. And the other, there are a couple more actually. There is an inherent fear of growth hormone in malignancy.
Yeah.
So if you have cachexia associated with some sort of malignancy, therefore it's not going to be acceptable. Even though I have some references to show that naturally released growth hormone, not injected, but naturally released, is not mitogenic to the extent that it's going to exacerbate the malignancy. All right, so that's one reason. It's the fear of malignancy, even though it's never been shown to cause spontaneous generation of cancer. The other one is that the drug industry is target oriented. So if you're going to have a problem with, what's a good example? You know, if you have a problem with high blood pressure, you get a molecule that targets the preganglionic, releaser, or you get a molecule that fits a receptor that's involved in the pathway. Growth hormone as a treatment for something like, you say, a gastrointestinal thing, IBS, whatever, is not, it doesn't fit the mold. The mold would have something that's going to, well, although they do have immunosuppressants that are not.
Biologics that have more side effects than.
Yeah, they do. Oh, they do. Believe me, I'm not knocking growth hormone. I'm just trying to answer your question about why these things are, they're not specific enough. So like all of these proton pump inhibitors for gastric problems, see, they're all like, they seem logical. So you got to be right next to the cause rather than downstream somewhere to get an indication, because then somebody's always going to come up in the review board and say, well, how do you know this doesn't do something else? And, so they try to avoid those kinds of issues. And of course, then there's the market. The market has to be huge nowadays. Like I said, a $50 million market in the 80s was not enough. That was just trivial.
Although more companies are entering the orphan drug market, which is a smaller population, obviously the prices are higher. So that's how they recoup their costs and make money. But anyways.
Well, just a comment. Recombinant growth hormone was an orphan drug, developed as an orphan drug. And
really?
Because it came in very fast, as you know, by Genentech. Genentech had that approval no time as an orphan drug for kids that couldn't grow. And then, of course, all hell went loose, and it's made tons of money for everybody except me.
So maybe we should be closing down now. We went over the hour. I had promised you to keep you for more than 45 minutes. So we can do, obviously we're gonna do a few of this, and we can get into more details on the different peptides and whether or not we have data on their use clinically. So I have to thank you once again for your time. You're like an encyclopedia of this in this field. I mean, who remembers a history like you do? And I was very impressed when I met you that there is so much work behind all these molecules, and we forget as patients, as users, all the brilliant work of people like you and others that devoted their lives to develop things that sometimes didn't get to market, didn't get approved, they were abandoned. I would have probably been destroyed as a researcher after spending years of my life on a molecule that had benefits, and yet pharmaceutical companies may have decided to drop them for later, for no use. So thank you so much. I encourage everybody to stay tuned for the next webinar we're going to have. I think Dr. Walker and I have one more scheduled this month. It's going to go more into details on clinical uses and the data on the different peptides and growth hormone releasing secretagogues. So thanks a lot, Dr. Walker.
Well, thanks for inviting me. I just have one comment. When you're in science, if you win 1% at a time, you're happy.
Like a lottery. I mean, well,
losing is most of the time what you get. So when you hit, it's a very satisfying thing. Thanks for inviting me. I appreciate it.
You take care. Bye bye.
Bye bye.